throughout our discussion, you talked about studies that were done, and I'm just curious to know what type of studies or research are you working on? What are things that you sort of look into that you're interested in, or maybe future studies?
Well, thanks for asking. And actually, just yesterday, we had published in a peer-reviewed journal, in a professional journal, a study on medical director time in nursing homes. I'm really excited about that. We haven't even announced it publicly yet. It was published yesterday afternoon, and so
Congratulations.
thank you. Yeah, I'm really excited. It's a journal of the American Geriatric Society, and so I think I mentioned before that we publish for every single nursing home in the country, we publish their staffing levels
Oh,
every single
really?
quarter. Yes, yeah. So a lot of people, just a very quick background, a lot of people for years lambasted so-called Obamacare and the Affordable Care Act, et cetera. But one of the important provisions that we and other advocates fought for was the requirement that nursing homes have to report their staffing. So the Affordable Care Act requires that nursing homes report their staffing for every single day. It's published on a quarterly basis, so they have to provide it to the federal government on a quarterly basis. And what we do is once that's published in the federal database, it's over 1 million lines of data. I mean, it's really obviously very overwhelming for most people. What we do is that we take the data and we average it out for the quarter, and we put it into searchable and sortable files. So people can download the file that we have done, and they can see an average for what their nursing home was providing in that quarter for RN staffing, for total nurse staffing, for contract staff, when someone doesn't actually work for the facility, and also for certain non-care staff like the administrator. How often is there an administrator there? How often is there a medical director there? How often is there a pharmacist? How many hours per day is there activity staff or social work staff?
Uh-huh.
Well, that's the information that we provide. Now, it's, as I said, for every nursing home in the country, but to be clear, it's for every nursing home in the country that is in compliance with those federal reporting requirements.
Okay.
And so they may, if someone's facility is not there, it's because they were out of compliance for that quarter. So when we've been doing this since 2017, when those data became public, for every single quarter. Once it comes out, we clean it up, we do all this, triple check it, etc. What I noticed when I was checking it over many, many years is that I would look at the non-care staff time. And of course, they always have to have some kind of, even if they're understaffed with nurses, there has to be somebody there, so there is some numbers. But I would see, like for medical director time, 0.0000 or 0.2, like such little time. Same thing for activity staff, same thing for social work staff. Like, what is going on with this information? We double check that the data are accurate. So we got funding from the New York Community Trust last year to do a national study and look at, okay, what is going on with these data? How often are there staff there? So our study that just came out yesterday found that medical directors who are responsible for ensuring that care is of a professional level in a facility, ensuring that infection control protocols are appropriate and are being, et cetera, which is important, of course, now in the age of COVID and with and influenza, et cetera, is extremely important. They have a lot of important responsibilities. What we found is that 36% of facilities reported no medical director time whatsoever.
36%?
Exactly.
Oh my gosh.
So how is care being supervised? How is care being overseen? Who's the professional? Don't forget, there's not regular. This is the doctor for the facility, essentially. Otherwise, and I don't want to say just nurses, because nurses are important, but it's a doctor who does the prescribing. It's a doctor who is guiding the professional care. So again, that study just came out yesterday in the Journal of the American Geriatric Society. We're going to put out an alert on it, and we're going to do some additional work because that focused on medical directors. But also, as I mentioned, we see too often, not always, too often, very little social work time, very little activity staff time. I think what I wanted to mention is that, like for activity staff, we were talking before about people with dementia and how, too often they're not getting the care that they need. So they wind up having so-called behaviors and they wind up getting doped up. activity staff is really important. If I had a loved one with dementia and I was putting them in a nursing home, I would look and see what is the activity staff. I would try to find, like for instance, in the database we put together, people can search. They can narrow it down to county or to city. So you could see by county, okay, what are the facilities in my county, the highest staffing, whether it be registered nurses or activity staff. And activity staff is really important because too often facilities provide the same activities for everybody. Like I mentioned before about the woman with dementia in the wheelchair who was wheeled in watching the same movie with everyone else that she couldn't really focus on, and said she had the lights shining in her eyes. But activity staff, the requirements for nursing homes is that everyone has the activities that are appropriate for them. Again, what CMS says over and over again is meeting the resident where they are. And it takes activity staff who are trained, who are competent, who know how to provide care and services to people with dementia to understand and to be able to provide those services. But if there's nobody there, if there's no activity staff, and all they're doing is setting up bingo and movies and turning on the TV movies in the afternoon, then people are not going to get that care, whether they are able to do more sophisticated things or whether there's someone with dementia who needs something that is appropriate for where they are. So activities is really important, and no one has really looked at this because, again, that this information just wasn't available in 2017, and you have to have the data there in order to. You need a few years of data, of course, in order
Yes.
for it to be meaningful.
Yes. As I'm listening to you, as you talk about activity care, recreational care, understanding the patient, these are all opportunities and avenues where you can assess the patient, not just
Yes.
having a bingo game, if you will, or dancing group or yoga
Yeah.
group nowadays. Really trying to get a sense of what meeting that patient where they're at. What comes to mind through my fundamental training and experience is we had a care group. We met with was the social worker meeting up with the vocational counselor, the recreational counselor versus the therapist versus their case manager and a multidisciplinary team to then talk about each different cases. And I wonder, does that happen in a nursing home?
It's required to happen in a nursing home, but too often those meetings. So every resident is, and for every resident, a facility is required to do a comprehensive assessment that includes not only their clinical needs, but also their psychosocial needs, their goals, backgrounds, cultural background, etc. And then from there, develop a plan of care that addresses all the things that were identified. And of course, that's where this meeting comes in, is to develop, the care planning meeting essentially. And it should happen, at least once a year. And if there's any changes, like for instance, if someone was faced with some of the examples I showed before, where the individual became agitated for some reason, that is when care plan is needed. Perhaps a new resident assessment is needed as well. And what we've done is we have put together some forms for families to make it easy for them to track issues, but also basic fact sheets on what is required. Because the federal, as I said, at the very start, the rules are really strong here for what a facility is supposed to do. And there's a whole list of things that are required to be a part of the resident assessment and care planning. But I almost always hear from residents and families and long-term care ombudsmen who help residents and families is that the meeting was like 10 minutes, or the meeting was scheduled at a time the child, the son or daughter of the resident lives in California, and the meeting was scheduled for 9 a.m. on a Wednesday, and
Okay.
9 a.m. Eastern time on a Wednesday, or at a time when the individual is working without even asking, without even consulting with them. And even if the person is there in person, that these meetings are short and very rote. This is what we're doing, blah, 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 and not a lot of opportunity for what is required under the federal rules. So all of our fact sheets, except for one or two, are just 2 pages long. They're front and back, so people can take them with them. They all cite carefully the federal rules. So as I say, when I talk to do a program for families, it's not just some bald guy that came in and said, these are my rights. You actually have the federal rules behind you to say, this is where the right comes from. And those resources families have used them, and residents have used them to advocate for stronger resident assessment and care planning processes, because those are really important.
Yeah, again, this is an incredible amount of information, and you're expanding my knowledge exponentially. As you
Thank you.
talk about and you share what is going on federally and how it affects the nursing home and the actual directly affects the patient, right? So another thing that comes to mind to me is sort of the training and education component for the nursing homes and the staffing. I know you talk about educational programs for families to get them empowered and informed as to what their rights are and what they should look to in a facility. But how does this sort of fall on the sort of responsibility of the facility to educate this? How's that being monitored and how's that being tracked?
Well, there are everything else pretty much. There are good requirements, but I would say it's not being well tracked at all. So there are requirements that, for instance, to provide nursing home care. And this is useful to know that it's very different from assisted living, where there are no federal requirements for providing care. In order to provide care for nursing homes, you have to be at least a certified nursing assistant, called
Yes.
the CNA.
Mhm.
And CNAs have to have, if I remember correctly, 75 hours of training under the federal rules. And I believe most states have a higher training requirement than that. We did do a study and report on state training requirements several years ago. So, many states have 100 hours of training. Some states have 150 hours of training, but you have to have at least 75 hours, and you have to be certified. You have to go through that whole process. And then facilities are also required to provide in-service training to their CNAs, and CNAs provide about 90% of what we call bedside care, of care to the
Okay.
residents.
Okay.
And the rest of the LPNs, licensed practical nurses, they provide some care. And then the registered nurses are really important because they don't necessarily provide a lot of hands-on care, but
Mm-hmm.
they are the ones responsible for overseeing the care provided by the LPNs and the CNAs. And
Oh,
they're
okay.
really,
Uh-huh.
the RNs are, generally speaking, again, like we mentioned before, there's virtually never a doctor in most facilities. So it's the RN who is the only one who is in the building who can actually assess a resident, who has the professional ability and training to do that. So RNs and LPNs are a lower level of professional nurse, but they're not the registered nurse. They can't, they can't do a resident assessment. There's certain other restrictions to their licensure, but those are professionals and they have professional requirements. And again, the CNA is really the requirements under the federal rules. I would say just very quickly, unfortunately, over the years, the industry, which is very, very powerful, has moved to undermine that. So now we have what in some states what are called medication aids. We have some states that are what are called feeding assistants. And those are things, I don't want to take up too much time, but those are things which sound like they're good, but really are not. So, for
Really?
instance, yes. So, a lot of states now, feds gave them permission to do this, allow feeding assistance. And of course, again, from a family member's perspective, of course, I want to see my loved one get food that he or she needs, or they need
Right.
to be, nourished, etc. And weight loss is a big issue in nursing homes. Dehydration is a big issue for nursing home residents. So that's really important. However, when you allow a facility to have a feeding assistant, essentially what you're doing is you are diminishing the job of the nurse aide. So the
Okay.
nurse aide is no longer the person who's providing that kind of care. And you have someone who's coming in who's just essentially, as the name says, just feeding residents. Feeding is actually a really important time, a really important care interaction.
Okay.
Because if you have, for instance, and a lot of residents have dementia, so many residents with dementia need queuing or chewing. Sometimes residents with dementia will have issues swallowing. They may pack their food. It may become a choking hazard.
Right.
Even in situations where that is not specifically the case, there is also that when you are with a resident, when you're helping them with their food, that is, again, a care interaction. That is a time. So if you have someone who's coming in who's doing these tasks, and now you've diminished the tasks of the CNA, is that you don't have people who are seeing your residents as a human being and are seeing, not only seeing them as a human being, but also seeing them in what's going on with them. So feeding, at the time when someone is being helped, if they need help with eating, is a time to see how do they look. Do they look depressed? Do they look happy? Are they more subdued? Do they seem uncomfortable? Those are all times to cue in on those things. Again, providing the 24-hour skilled nursing care that facilities are supposed to provide. If you just have the feeding system coming in, they're not going to know to do those other things. They certainly may not have the ability to provide appropriate dementia care feeding assistance, but they also are not there to provide kind of the looking at the person as what's going on, knowing the person from yesterday and last week to today, to see that
Yes.
maybe that person has had a change. And then what you've done to the CNA is essentially you've made them into someone who's only cleaning up diapers.
Mm.
So I don't mean to state it too.
No, no, this is
Yeah,
important.
but
Yeah.
yeah. So that and that gets into, we were talking about staffing before, and the reasons why there's short staffing. The biggest reason why there's short staffing is because nursing homes have over 50% turnover. Why do they have over 50% turnover? Because these are crummy jobs, and too often.
Okay.
They don't have to be. People come in and they want to do a good job. They want to be providing care. And what they find out is that they're only cleaning up urine on the floor. They're only doing that. And someone else is actually sitting with the resident and dining with them and helping them. They're not providing care. They're just doing these tasks that are dangerous. Being a CNA is one of the most dangerous positions in the United States.
Really?
Yes, yeah. If you look at I think it's the Census Bureau. They're
Wow.
always listed in the top 3 as among the most dangerous professions, along with like mining and truck driving.
Wow.
Yes. So they're low pay, they're dangerous, and they become very diminished. It's not a care position, it becomes a task position. So you have this turnover, and that's why facilities, one reason why they're understaffed is because the industry will say, oh, we can't find more staff. Well, the problem isn't that you can't find more. The problem is that you're not keeping them because they're leaving. Half of your staff, if not more, are leaving every single year.
Wow.
What kind of continuity is that for your residents? What kind of setting are you providing for your workers?
Wow. That's incredible.
Yeah. So
Yeah.
a lot of these things, it really helps to have to. I don't think it's fair to ask families to be experts. I mean, that's not fair, and it's really not possible. And that's why we try to provide some of these fact sheets, etc., to provide resources for them so they can go and see. They can look at our fact sheets and kind of look and see, is there one that addresses the issue that I'm seeing, to help support their knowledge and understanding of that.
So, as you're talking about, ways where these facilities are trying to cut costs, i.e., nursing homes and assisted living facilities, they are hiring a feeder, and the nurse's aide job has sort of now it's now sort of exclusive to diaper changing. It reminds me of sort of this fragmentation of care, right?
Mm-hmm.
Because if you don't have someone involved and monitoring your daily activities, right? Dressing, changing, showering, brushing your teeth, eating your meals, right? Taking you to doctor's appointments or to different activities. That's how you really do get an evaluation, right? Or an assessment of the patient. When you mention this sort of fragmentation of care, I can see then an added challenge or dimension to the quality of care, or even care with dignity, where these facilities are expected to have or to do or to actually put in place.
Exactly. And it's not every facility, and there are good facilities that are doing it. So I think it's worth mentioning that, as I said before, most facilities don't have enough staff just to meet residents' basic clinical needs. And that statement is based upon a federal study, a landmark study that was conducted in 2001, that found you need to have a certain level of staffing, 4.1 hours to be precise, of nursing staff time per resident per day, just to meet their clinical needs. And the average staffing in nursing homes is about 3.68. So significantly lower.
Wow.
4.1 is the minimum, and you have 3.68. But the
And when you say
important reason why I
nursing,
meant,
when you say
yeah,
nursing, you mean nurses aid too, right?
yes. So the
Yes.
nurses aid, not including feeding assistants, because
Okay.
they don't count because they're not care providers. But and not, I would say, I don't know for certain, but I would say most facilities probably do not use feeding assistants, but too many do,
Okay.
and that is still a real concern for us. So we have the average is 3.68 approximately. So it's lower, but it's worthwhile to note that 25% of facilities have 4.1 hours or more of nursing staff time. So facilities, there are many facilities that do have enough enough staff, care staff, I should say, excuse me. And the other important takeaway from that, which I tell legislators, both state and federal, all the time, is that we're not talking. We have 15,000 nursing homes in this country. We're not saying that 5 or 6 of them have enough staff. I'm saying 25% of them have enough staff. It could be done, but if you're not enforcing the rules, it's voluntary. And in an environment where you have this corporatization and a big profit drive, the movement is to cut down on staffing, because cutting down on staffing is the easiest way to save money. You can't chop up the building. It's hard to, you can't put more than 2 people in a bed, or more than 1 person in the bed, I should say. You can't start
Right.
throwing, but you can cut down staffing, and if the rules aren't being enforced, you can do that with impunity. But really the important thing is that 25% of facilities approximately are doing it. So if they can do it, why can't others? It shouldn't be voluntary. It should be that everyone is doing this because that's what they're getting paid for.
And does the reimbursement rate also affects the type of care provided? What I mean is, are nurses aid reimbursed specific amount of dollars per day or per hour? Would that have an effect on it as well?
So the facility is reimbursed based upon the resident. And there's different reimbursement
Oh, okay.
mechanisms, but there's reimbursement that's federally determined for Medicare for those short-term rehab people, and then Medicaid reimbursement is based upon the states, jointly paid for by the state and federal government. But it's reimbursement for resident for care. It's not reimbursement for specifically for staffing. So
Okay.
that's something we actually, and another study that was published that we had, that we participated in, I should say, that was published in a peer-reviewed journal last year, looked at nursing home finances, looked at where the money is going, and that's one thing that we found, is that looking at that there is a certain amount of money that goes to staffing, there's a certain amount of money that goes for building, et cetera. There's a lot of money that goes to what are called related parties, other companies that the nursing homes themselves own, which is a way of kind of hiding profits too often. But
Okay.
I know we're talking about a lot of stuff here already, so I don't want to get into that. But essentially, there's not a lot of accountability in respect to what you're saying, in respect to ensuring that there is a living wage, and in respect to ensuring that the facility is taking a certain amount of its money and putting it into staffing and putting it into care. And one of the things that we did a report last year or the year before that looked at what some states are doing, because there are now several states, New York, Massachusetts, New Jersey, if I remember correctly, Pennsylvania, have implemented what are called minimum spending requirements. So New York, for instance, requires that 70% of the money that nursing homes receive go towards care. We think
Okay.
it should be at least 85%. This
Okay.
actually really comes from the Affordable Care Act, requires that insurance companies put at least 85% of the money back into spending on care for their beneficiaries. So this should be the same thing for nursing homes, limiting the amount of money that can go to administration or that can go into profits, etc.
Yeah. How does it work with, in my previous interviews, a lot of elders or families who are caretakers, caregivers, they talk about the Medicare Advantage plans. And does that have an impact on the type of care they receive as well? because families struggle immensely with the different types of insurance and what to choose and
Hmm.
what not to choose. And they often, what I'm learning is that it's not based on their medical or mental health needs or biopsychosocial needs. It's based on maybe more financial needs. But does that have a role in, or does play a role in the type of care and services they receive in nursing homes and assisted living
Yeah,
facilities?
well, assisted living would, I don't think that's, I'm just trying to think. I mean, assisted living is mostly private pay with some, now I think 48 states have a waiver program. And so some of their assisted living is paid for through Medicaid, but the Medicare really pays for in nursing homes, the short-term rehab. And I am not an expert. I want to be very careful on
Sure.
those those capitated plans. It's funny because we were just talking about this at a staff meeting this morning. So does it affect the care that is provided to nursing home residents? I think that what we see from our perspective is facilities concerned that they get a less of a reimbursement rate from the Medicare Advantage than they do from traditional Medicare because of how those programs run. There's also, and this is, we've talked about a lot, so I'm just conscious of that
Yeah,
too, to
sure.
bring in
Take your time.
other
Yeah,
topics.
sure.
But there was actually a journal article that just came out recently that I read over the weekend that talked about how nursing homes can have their own Medicare Advantage program to bring in that money to themselves. Because the purpose of these Medicare Advantage programs is essentially and again, I want to be careful and not overspeak what I know, but they tend to capitate costs. So the
Right.
Medicare Advantage program say we'll get $600 a month or $1,000, whatever it is, and then from there they're for each one of their members, and then they're meeting out the cost. They're paying for home care, they're paying for prescription drugs, they're paying for whatever. Some things are required to be paid for. Some things are extra, like I had today for being driven to doctor's appointments, other stuff, or
Okay.
grocery help. That's different. So one of this article talked about nursing homes having their own what's called an ISNP, an institutionalized plan themselves, so that they can keep all the money. And the reason why I think it's worth mentioning is a couple fold. One is that it just speaks to how sophisticated the industry is, how sophisticated and corporatized healthcare has become in this country, and how sophisticated nursing home care in particular has become, which is where, of course, my area of expertise. But the other thing I would mention is that all of these are ways in which to try to improve some quality and certainly financial accountability into the system. And from my perspective, there's not a lot that has really worked very well in that area. Is that we tend not to see higher quality. We tend to see reports with the Medicare Advantage of maybe people not getting the care that they need too
Mm-hmm.
often because when it becomes more expensive. And those vary because those plans really vary and the state requirements for them really vary. I would say a really good source, if you're interested in exploring this more, would be the Center for Medicare Advocacy, because they really focus on this and they're really the experts on this. And actually, when I was reading myself over the weekend, reading this new article, I went back to an article that was written by the Center for Medicare Advocacy last year, which I remembered reading. So they're a terrific organization, and they're based in Connecticut, but they have a DC office as well. And it's MedicareAdvocacy.org is their website. But they can really, I think, in my view, better than anyone else, they're really the experts on that.
Yes, Richard, I know that I've used up a lot of your time and I want to be very
Thank you.
sensitive.
Yeah, thanks. And thanks for your patience again. I appreciate it. They're going to come
Yeah,
back probably at the end of
yeah,
it.
of your time. I think just listening to you is so informative. And I know that, the listeners of the podcast will learn an incredible amount of information. I think I am very intrigued with our discussion and so much incredible information you have shared and
Thank you.
valuable information about the whole nursing home and assisted living environment. So much so that I think we may have to do, if later on we can talk offline, if your time permits, another discussion because there's so much to cover. But I'll sum it up today. I have two questions really that I meant to ask you earlier. Is the bipartisan aspect of the work that you do? Can you just share with us what that means?
Actually, what I said was nonpartisan. So we're not a partisan
Sorry,
organization.
nonpartisan.
Yeah,
Correct.
yeah.
Yes, nonpartisan. Yeah.
And really, it gets to that. Even though we are an advocacy organization, we're working to, on behalf of the interests of residents and of their families. Is that we are not a we don't we do a very little bit of lobbying in support of bills and stuff, but mostly it's really just to ensure that the existing rules are implemented in the lives of residents, and we do see that as a nonpartisan issue. So we're not a Democrat, we're not Republican. There are certainly, I think, strengths and weaknesses to the different parties in terms of what they do. And frankly, more of the resident protections, as with everything else, any other type of industry, tend to come from the Democratic side, and more of the cutting away of standards or accountability tend to come from the Republican side, but not always. I mean, we've had some very powerful, and we'd like to get back to that. We're in a very different era in this country politically nowadays than we have been in the past. But, in earlier years, we had people from both sides that were very intent on improving not just the accountability for care and safety, but also the accountability for where public funds were going. Because these are billions of dollars excuse me, that are coming from taxpayers that are paying for this care. And too often facilities are frankly are acting fraudulently. They're accepting money to meet a certain standard of care, and they're not providing that, but they're still taking the money.
Thank you.
Yeah, so we really try to be independent and again, a useful, trustworthy resource, no matter what political background someone has.
Thank you for sharing that. And my last question is, what got you into elder care?
I completely fell into it. I went to law school, and I always was interested in doing policy work and kind of civil rights type work. And I went to Howard University in DC, and I had some wonderful professors who were just doing cutting edge work in civil rights, both here, in the United States and internationally. And but I actually really just fell into it. I was looking to kind of build a career in this way, and the associate director position in my organization came up, and the person who was the director at the time was and is extremely smart, extremely dedicated, and it was very inspiring, frankly. And I really, I think because the population, the people that we're fighting for, is so vulnerable and too often can't speak for themselves, that to me it's just been very worthwhile and also very intellectually interesting and challenging. How do you help people who can't always speak for themselves be a voice for themselves, and how can you help to be a voice for them? Every way possible, from policy to educating those people and their families and those people who are working with them. So thank you for asking that.
Yes, thank you very, very much for your time, for your dedication, for the work that you do, for informing us about so many aspects about long-term care, nursing homes, rehab facilities, and assisted living. So thank you very much.
Thank you, Harlem. I really appreciate it. This has been
Yeah,
really interesting, and I hope useful.